said when somebody's going to have a lecture, there's no introduction needed and necessary. And in this case, it really is pretty true, actually. I suspect everybody in this room has probably interacted with Steve in some way. And he's a true innovator. Those of you who don't know him, he's a true innovator and an absolute godfather of British urology and andrology. It's not just in andrology. He's actually also a trainer and an educator, and his work in the curriculum, ISCP, intercollegiate board, it goes on and on and on. So I won't cut into his talk too much. It's a measure of the esteem that he's held. He's going to receive the BAUS Gold Medal this evening at the drinks reception, so I'd encourage you to go there to support him and see that. He's a fantastic friend, and most importantly, he's a top bloke. Steve.
Thanks, Duncan. It's nice to see you all here. Nice to see that people are still interested in andrology. I'm going to spend the next half hour, hopefully, looking backwards rather than forwards. And I'm going to give you some sort of rough idea as to what surgical training, urological training, and particularly andrological training was like over the last 30 years. But I'm not actually going to start 30 years ago. I'm going to start 40 years ago. That was the year of the Queen's Silver Jubilee, the year that Apple brought its first model out, the year that there was the first digital recording. Concorde took its first flight. Virginia Wade, do you remember Virginia Wade? She won the Wimbledon women's title. It was also the year that Enterprise first went into space, and there was the maiden flight of Concorde. Now, one of those things that was on that slide that I didn't talk about was Elvis. Now, Elvis died in August 1977, and it was exactly 3 weeks after I'd started my first house job. So it was something that I remember really, really clearly. Now, you've got to imagine that the world was a very, very different place in 1977. There was no metronidazole, so infant mortality from perforated appendicitis was 50%. There were no H2 antagonists, so my last night on call as a general surgical registrar at Mary's in London, I did 3 gastrectomies. There were no high dependency units. Patients took their chance. There were no CT scanners, even as far as the early 1980s. So if you had somebody come in with a major head injury, you may have to put them in an ambulance and send them to a regional centre just for a CT scan. There was limited rigid endoscopy. There was very embryo-flexible endoscopy. And at that time, outside of gynecology, there was no laparoscopy at all. If you needed a urodynamic study done on a patient, then you often had to send them to a regional unit. Otherwise, the patient got a TURP. There were no drugs for benign prostatic hypertrophy. So in my 3 years as a senior registrar, I did 1,000 TURs. And in fact, my initial experience of prostatectomy was as a general surgeon, and my first 50 prostatectomies were all done open. In 1983, I went to the St. Peter's Hospitals Group in the Institute of Urology in London. And there were some notable names on the staff of those hospitals at that time. But perhaps the most influential on the totality of my career was John Pryor. John had expressed an interest in andrology, and he was the only person, realistically, who was doing any form of complex work in impotence and in male factor infertility. Now, John was an exceptional individual because he believed that sharing information, collaborating with others, and producing things academically were tremendously important. He believed that any information you had should be shared with others, any techniques you used should be shared, and more importantly, the trainees should come in, they should get a taste for the specialty, and then disseminate back to where they had come from and utilize that information. He made strong bridges with people both within the specialty, nationally and internationally, and with other patient-related groups. He also was heavily involved in creating links with industry, which have continued to this day. And that was very, very different, because up until that time, every institution that professed a particular area of expertise had a large wall up around it and fought everybody that came up with what they thought was a better idea. Now, we've heard about surgical training that people can expect these days. Well, when I was training in urology between 83 and 88, there was no working time directive, so you could work anything up to 100 hours a week. You had already got your fellowship by the time you started training, so there was no defined career structure. You could go to any number of different places and gain your experience, and all of that experience was in an apprenticeship-style training. See one, do one, teach one. There was an SAC, but the SAC was much more concerned with ensuring that a centre had the ability to train individuals and wasn't particularly bothered about the trainees. There were very limited training courses, there was no Office of Education, and there was no knowledge or competency assessment throughout your training. And perhaps most importantly, there was very little subspecialist exposure. A lot of people didn't even know about impotence or infertility, let alone penile bends. So, over the last 30 years, as far as andrology was concerned, first of all, there was impotence, and to a greater or lesser extent, there was male factor infertility. Now, John Pryor had limited tools at his disposal back in the early 1980s to manage men with erectile dysfunction. Very few of them turned up on the day with their partner. Very few of them were prepared to talk honestly. And of course, we had no time at all to go in depth into the complexities of Masters and Johnson type psychosexual therapy. It raised in me the concept that performance-related anxiety is something that is important in dealing with men with erectile problems. But that wasn't something that was well known at that point. Yes, there were oral agents such as yohimbine. This is a bark extract from this Pausinyastalia yohimbi tree, which is grown in Africa, but it wasn't particularly effective, although, as you'll see, it's 100% potent. Of course, if surgeons cannot find an answer, then what do? They roll up their sleeves and say, we can do something about this. Now, it goes back to the early 1950s when Goodwin and Scott first implanted a polyethylene device into a penis, but it was Michael Small in 1975 who came up with the first tangible penile prosthesis. And if somebody did not improve, no matter what the underlying cause of their erectile dysfunction, they frequently ended up having a penile prosthesis inserted. That is very difficult to understand these days. Now, back in the early 1980s, there were no particular investigations available. There was a forerunner of the Rigiscan, and those of us that went through the Institute of Urology will remember getting the call from St. Peter's to go and put the slings onto a patient who had come in for a nocturnal erectile tumescence test. We didn't know what we were doing, we put them on, we didn't know what we were going to do when we took them off. But it did at least give the sort of idea that perhaps there were psychogenic and somatic causes for erectile dysfunction. And people began to think about the basic mechanics of erection, that there needed to be more blood going in or less blood getting out of the penis, but there certainly was no understanding of the molecular biology of this situation. So there were a lot of men out there, a lot of them in the States in particular, who wanted a treatment. And as ever, treatment came to the fore rather than having an underlying scientific basis. And the person who really pushed this boat off from the shore was a hand surgeon, plastic surgeon from the Albert Einstein College of Medicine, Erich Strauch, who took out this patent for a penile prosthesis in 1973. He clearly thought that he was onto something, but he didn't know what, so he very rapidly sold that on to AMS and said, don't know what to do with this, but here, you have it and see what you can do with it. And AMS then joined up with this chap, Frank Brantley Scott, who looked not only at the penile prosthesis, but also the artificial sphincter. They both worked on a similar principle, and he published his initial papers in 1973. Sadly, Brantley Scott was killed in an aeroplane accident, that the plane he was piloting. Now, that penile prosthesis, through various iterations and changes, is the same device that we use today. And I think it's part and parcel of John Pryor's legacy that there have been these very strong associations between our colleagues in North America, particularly Cully Carson and Steve Wilson, with the people who have pushed this technology forward in the UK, namely David and Tim Terry. As I said, the devices, the ones which are currently available, are very much the same as Brantley Scott had envisaged in 1973. More technical changes, fewer mechanical breakdowns, but they are basically unchanged. Intrapenile agents first came to the fore as a consequence of an accident. And that was when this chap, Ronald Virag, a French vascular surgeon, inadvertently administered papaverine into the epigastric artery and found that a 2-hour erection ensued. And he thought, maybe we could actually put the injection directly into the penis and the man would be able to get an erection. And of course, he found that that was precisely what happened. Now, papaverine wasn't the only agent that was out there. Another agent, phentolamine, was being looked at by Giles Brindley. And Giles Brindley was a professor of experimental physiology at the Institute of Psychiatry, and he is perhaps most famous for his demonstration of the effect of phentolamine at the 78th AUA meeting in Las Vegas. He went along to this satellite evening meeting of the Urodynamic Society, having injected himself with phentolamine. He got up, he gave his lecture, and at the end of the lecture, he dropped his joggers to demonstrate the erection, but not content with suggesting to the audience that this was an effective treatment for erectile dysfunction, he walked around the auditorium and invited various attendees to actually feel the quality of the goods. Injectable agents were popularized in this country by Clive Gingell in Bristol, and he had a massive impact on the uptake of both papaverine and phentolamine. But it was Virag who, in 1987, first utilized the drug alprostadil. And this, of course, is something that acts via cyclic AMP to cause smooth muscle relaxation, which causes a dilatation of the central arterioles, an increase in the corpus cavernosal volume, and compression of the veins. In other words, increasing the blood flow in and decreasing the venous drainage out. Now, there are 3 dates that I want you to remember. One of them I think you probably already know, but I can remember February the 21st, 1994, and Martin Lancashire was here or hereabouts, because we held a clinic on a Saturday morning. We saw 100 men with erectile dysfunction the following week, and there were some pretty spectacular results with this totally unselected population being given a drug that we really didn't know what to do with. Those of us that are old enough will remember this little blue box that each dose of Caverject came in, a freeze-dried capsule. You had to mix it all up and then inject it. And following that, there were a number of drugs which became available, some of which were, and many of which were not licensed for clinical use. But if you're a man with problems with your erections, you'll go to any lengths to try and deal with that problem if there is no other way in which it can be treated. So those drugs were used commonly to treat erectile problems. And of course, you've got these bimix, trimix, and quadmix, which just were combinations of other drugs. You just kept adding another drug to it to give you something which was going to have a stronger effect. But the basic principle, again, is exactly what we use these days. So we are going back to 1994 for intracavernosal injection. As I've said, initially you needed to mix the drug up yourself, get it into a syringe and inject it. But then in 1998, a gentleman working in the States, an engineer, said, well, why can't you mix this freeze-dried powder with fluid using just one syringe? And this was his patent for the dual-chamber syringe, which then became in common use andrologically in 2002. Of course, we know the problems that there have been with its supply since, but that means of utilizing Caverject has been around now for 15 years. People thought, well, if you can give alprostadil into the corpus cavernosum and it produces an erection, why can't you just put it down the urethra? And interestingly, just 3 years after the Caverject injection came out, the medicated urethral system for erection, or MUSE, was popularized, but as we all know, it wasn't particularly effective. So it's hardly surprising that when Vitaros came out in 2009, that it equally was not dreadfully effective. Well, what about the good old vacuum erection device? Well, that's been around for years. In fact, it was around in the 19th century. But it wasn't until Geddings-Osborne patented his erection device in 1983 that the use of VEDs really got off the ground. And this was something that was driven forward by his son, Julian. And again, really very little has changed as far as vacuum erection devices are concerned. It's still the same pump, still the same cylinder. The pump may be different. It may be mechanical, it may be electrical, and you still need to use a ring. Now, in 1989, a number of scientists at Pfizer down in Sandwich in Kent found this drug, UK 92480, that inhibited PDE5s, and they thought, this would be useful for treating hypertension. It would be useful for treating ischemic heart disease because it will, via cyclic GMP, cause an increase in blood flow. What they found is that it caused an erection, and this was something they wished to develop. And this was something that they wished to develop with a British team, and that British team consisted of Clive Gingell and Ian Nerdley, who went along to the AUA meeting in Orlando in May '96 and announced to the world the presence of sildenafil or Viagra. And this had a massive effect on Pfizer's stock share. Well, of course, what happens when other drug companies see that amount of money or wonga being made by one of their competitors? They want a piece of the action. However, it took another 2 years before Viagra actually got to market, and it wasn't until September 98 that the European Medicines Agency said that it could be used on patients in Europe. The second date I want you to remember is September the 14th, 1998. And this is probably a date that you remember already. And the reason for that is because, like me, you have been strictured for the last 15 years by prescribing restrictions which say that you cannot give this drug except for a number of circumscribed conditions unless the patient was being treated for erectile dysfunction before the 14th September 1998. So if you were on any treatment up to that date, you could be prescribed Viagra. Now, Viagra was a huge money spinner, but of course it had its downsides, and we all remember the stories of people going blind, people having coronaries whilst having sex, etc., etc., etc. So other companies looked at other products, and those of us that remember apomorphine when it came out in 2001 will remember the patients who came back and saying, I didn't feel like sex because I just felt nauseated and was throwing up all the time. So Prima came and went very, very quickly. Tadalafil and vardenafil followed sildenafil after a reasonable gap. And round about 2007, so just over 10 years ago, the European Commission approved the low-dose use of Cialis as a continuous dosing medication. Now, I looked at these formulae long and hard, and I could see very little similarity between them. So if anybody can see any similarity, then I'll be pleased to hear from them. And it came as a bit of a surprise to me that in 2012, Vivus announced that it was launching another PDE5 inhibitor in the form of avanafil. And again, its structure seems to bear little relation to its forerunners. Now, Viagra came and Viagra went. So in 2013, the UK patent on Viagra expired so that generic prescription of sildenafil could be made for any condition. So that's the third date I want you to remember, June the 21st, 2013, when the world changed. And indeed, in 2017, the MRHA suggested that sildenafil by Pfizer should be available as a pharmacy medicine and held a consultation which ended this April. The interesting thing about the prescription of PDE5 inhibitors is that over the last 3 years, the number of prescriptions for sildenafil has gone up markedly, whereas if you look in the bottom graph, the amount of income that people have accrued from the use of or the prescription of sildenafil has gone down markedly. There has been little change in the investigation of men with erectile dysfunction. Arteriography was popular with vascular surgeons just like Virag, who wanted to reconstruct the penis, get a better blood supply. That didn't work particularly well. People used cavernosography to try and determine whether venous leaks were present or not, but in most people's experience, venous leaks are omnipresent. The person who invented a test for erectile dysfunction was Tom Liu, but in fact his greatest contribution was to the demonstration of the importance of basic blood tests to determine whether somebody had somatic erectile dysfunction or not. You'll notice a slightly less than subtle transition from impotence via erectile dysfunction to male sexual dysfunction, and male sexual dysfunction now encompasses very many of the facets of andrology that we see on an everyday basis. Sexual dysfunction was shown to be a component of a number of different diseases by the Massachusetts Male Aging Study, and indeed it was shown that erectile dysfunction can be something that is part and parcel or an indicator of cardiac disease, and the person who put that on the map was Graham Jackson back in 2003. You remember briefly that I said male factor infertility was another of John Pryor's interests, and up until 1983 there were very few in the ways in which a man with azoospermia or severe oligozoospermia could be treated. And indeed, Tim Hargreave, who got the St. Peter's Medal in 2014 with Ian Eardley, wondered back in 1986 whether there was any point in carrying out an infertility clinic because there was very little you could do other than counsel those patients. These two men put the management of male factor infertility on the map, Patrick Steptoe and Robert Edwards. And Robert Edwards, who's a physiologist, got the Nobel Prize for this in 2010. There was little to be gained from investigating people with azoospermia, either by transrectal ultrasound or magnetic resonance scanning. And it wasn't until this Belgian urologist, André van Sterdegem, and his unit demonstrated this technique of intracytoplasmic sperm injection that things moved forward. This US-based pair of Sherman Silber, a microsurgeon, and Ricardo Ash really put things on the map, and there were a number of surgical sperm retrieval techniques that they initiated and popularized and which are widely used today to retrieve sperm. It wasn't, however, until 96 or 97 that the relevance of microdeletions became apparent, and this had an impact upon the outcome from surgical sperm retrieval and IVF and ICSI. It was Peter Schlegel who first demonstrated the technique of microdissection TZ, where under a microscope individual tubules were found and then sampled, and the best quality sperm within that testicle was then harvested. And the two people who really have put this technique on the map in the UK have been Sux Minas and John Ramsey. So, where have we got to over the last 30 years? Well, I think that this title from a very recent and current paper from the Journal of Sexual Medicine says it all. Here's David Ralph in the middle of all of these European and North American collaborators saying this is what we should be doing. So, in conclusion, if one looks back at what John Pryor's vision was, we now have collaborative research, there are masterclasses and fellowships, although perhaps they're not as ideal as they should be. We collaborate with a lot of other specialty areas. We've had a section of andrology since 2003. We work closely with our industry partners, and we produce a number of other bits of information. So I think we have come a long way in 30 years in andrology. It's not all bad.